Okay, so we're gathered here today on the 8th of October with Dr. Lorraine Azzopardi, who is the resident pediatric psychiatrist at SIPS, the Child and Young People Services, which is found at St. Luke's Hospital. And some time ago, our colleague Carola and even myself, we had asked Dr. Lorraine if she would be willing to kindly give us a presentation of sorts. And we agreed on this topic of oppositional and defiance because we see that several of our children, not all, but several of our children can have this comorbid, coexisting condition of ODD. And as we can see, it creates a lot of interest because having a child with ADHD and ODD makes life a lot more difficult. So I would like to thank you, Dr. Lorraine, because I know this is extra for you, and I really appreciate that you're doing this for us. And that's more so that we can record it so that the people who couldn't attend will be able to benefit from this lecture. So if you like, I believe you have the hosting rights. You can
Yes.
share your screen, and I'd like you to introduce yourself with anything that you think is better.
Well, thank you for the invite. First of all, you know, I like this sort of thing. You mentioned St. Luke's Hospital. I would also be in Gozo. So for those of you
Yes.
who would like help in Gozo, I'm also in Gozo General Hospital in the SIPS over there every 2 weeks. Okay. Well, let's share the second. Okay, hopefully it should work like that. So as Pamela was saying, I'm a consultant child psychiatrist, and I work in the government sector. Obviously, a good chunk of our work does involve seeing young children and adults and young people with ADHD, some of who would have oppositional defiant disorder. The process that what would happen, so people would be referred to SIPS but via a referral ticket, okay, from your doctor or from CDAU, or on suggestion of maybe a teacher at school. And we would then open a file. Okay, one of my colleagues would take an initial assessment. We discuss the problems as a team together and decide between us what would be the most appropriate way forward. And depending on what we are seeing, we will offer you an assessment, okay, of your child, and obviously management depending on your main concerns or the child's concerns. Okay, so let's go on. So what is oppositional defiant disorder, first and foremost? Just a second, I on the screen. There we go. It's a repetitive and persistent pattern of opposition, defiant, disobedient, and disruptive behaviors towards authority figures persisting for at least 6 months. Okay, so what we have is children that repeatedly defy authority or disobey us. Okay. Pam, what do you think, before I continue, what do you think most people would like to ask questions at the end? What?
I knowing us, we might go off on a tangent, and I'm afraid that they will stop your flow of your PowerPoint, which I know I would like to see the full PowerPoint.
Okay.
So everyone is okay. I think we should leave the questions for the end, if that's okay.
If you don't want to forget, what you can do also, there is a function, there's a chat function, and you can ask the question on the chat, and then we'll go through them slowly so that you don't forget the question till the end, or maybe if you're shy or whatever. So let me continue. So these are ICD, so it might appear a bit difficult, but I tried to include as much information as possible anyway, and I will explain it. So when we come to diagnosing conditions, we usually use criteria, okay? And these criteria, we have the European ones, and these are the ones that I will be describing now, and then there are the American ones, okay? So the ICD-10 one, if you ever hear it mentioned, these are the European ones. And according to ICD-10 criteria, a child with ODD would be showing persistently defiance, disobedience, and hostility towards authority figures. So towards, for example, parents, teachers, maybe the coach in PE and in sport, okay? With loss of temper, they argue with you, they may become angry, sometimes vindictive, okay? Which means bil-Malti pattu ilek ukoll, okay? Or other negative behaviors, okay? Such as throwing things maybe, or sulking, or refusing to do what you're asking, okay? This sort of behavior. It usually begins in childhood, and it is recurrent, okay? So as we know, most children will be negative, defiant, disobedient, and hostile, okay? But this is recurrent. It will be for frequently and for a lasting period of time. So it's not a phase, okay? So it's not the terrible tools, for example, okay? And you have to have at least 4 of the following, okay? So losing temper, arguing with adults, actively defying or refusing to comply with requests or rules, deliberately annoying others, so doing things on purpose to annoy you, blaming others, so you tell them, what did you do? Did you drop the cup of water? And they'll tell you, no, my sister did it, okay? And easily annoyed or often angry or resentful. As you see, all these things that I mentioned, all children do them, okay? So it's not just being present, okay? It's the severity, the persistence, and doing them everywhere. These are the DSM criteria, so the American ones. As you see, they are very similar, but they divide them into 3 chunks, which, if you look up research, can be a bit important. These 3 domains, we call them, okay? I will mention a few later. So there's the anger and the irritability, okay? There's the argumentativeness and the defiance, and there's the vindictiveness. And the vindictiveness for DSM criteria has to have occurred at least twice in the previous 6 months. As I'm saying, the frequency, severity, and how long the symptoms persist is what will distinguish it from other children. And when we are assessing, not only do we look out for these symptoms and how severe, we also compare with other children of the same age, developmental age to be exact. Okay, so if a child has learning difficulties and is still immature developmentally compared to other children his age, his biological age, we compare to children who are similar to him in speech, in the level of development, okay? This is why very often when we are trying to make a diagnosis, we will come to school and observe the child in class. We are trying to see whether there is difference in behavior, okay? Apart from this comparison and the severity, there is also this distress, okay? So the child would either be distressed himself or herself, or in this case, distressing others. This behavior also has a negative impact on the social function of the child, on his educational development, on the occupational if they're a bit older, right? And in other important areas of function. So it's not only just present, it's present and affecting the child in day-to-day life. Unlike ADHD, which for diagnosis must be pervasive, okay? So when we say a child has ADHD, we need to see the ADHD symptoms in more than one setting, okay? So for example, at home and in the classroom, or in clinic and at home, okay? In ODD, it can be present in only one setting. So you can have oppositional behaviors only at school or only at home, okay? Very often it is present in only one setting, in fact, okay? If it's present in more than one setting, this indicates severity, obviously, and it's creating more problems. So ADHD and learning difficulties are frequently present with ODD. ADHD, I'm assuming many of you know. For those that don't, it's attention deficit hyperactive disorder, a neurodevelopmental condition, so a condition that we are born with. And learning difficulties is any sort of difficulty, for example, in speech or in colloquially the IQ, okay? So in the cognitive function of the child, and these sort of difficulties, for example, or for example, dyslexia, or how well the child understands language or expresses himself, okay? So these children all are at more risk of ODD. ODD does not include more aggressive behaviors that are usually associated with another condition that we call conduct disorder, okay? And however, many children that as young children are diagnosed with ODD might eventually go on to be diagnosed with conduct disorder. And for the sake of completion, I'm going to explain what conduct disorder is so that you can see the difference, okay? Conduct disorder is usually diagnosed in childhood or adolescence, okay? It's typically you would have aggressive behavior, okay? So not just these outbursts, they would be aggressive, physically aggressive or verbally aggressive, deceitful, okay, which means trying to do things behind your back, or for example, tricking other children into doing naughty things instead, destruction of property, okay, and breaking of rules. And this is persistent and repetitive, and it occurs within a 1 year period. This behavior would be violating the rights of others, okay, or breaking the norms for that society, okay? So depending on the society you're living with, not all our cultures are the same, but they would be breaking these social norms, okay? It causes or threatens other people or animals, okay? So there's the threat of harm to others, but there might be also, for example, loss of property or damage, theft, okay? It's usually before 18, and it's more serious than a little joke, okay? Or for example, hiding something from your parents. This is breaking of rules, serious breaking of rules and aggression, okay? In these children, however, self-esteem is usually low, and they have difficulty developing social relationships. Some of them, they have a lack of concern whether, so some of them might have a lack of concern for others, and some there might be this concern. So this is not always the same. Okay, so going back to ODD, that was a little bracket about conduct disorder so that you can distinguish one from the other, okay? Prevalence. So how common is this ODD? Okay, so the numbers, I threw some percentages there, but if you read different studies, you will find different percentages, okay? I would say 6 to 10% is a good average, okay, between the various studies. This is in non-clinical samples, so in the average population when you see them, for example, in school, okay? In low-income families, however, for example, you can get up to 35% because there's a higher risk in low-income families. In a particular study, okay, in Australia, they found that ODD was one of the most common diagnoses that was resulting in hospitalization to a psychiatric unit, okay? It is more common in preschool boys than in girls, okay? And usually when it becomes a problem with girls, it's usually later on, round about puberty, okay? Most often, the onset of ODD is usually early. So sometimes, very often actually, before preschool, okay, before they start year 1. And it starts to, the behavior starts to increase or worsen, okay? However, this is not always the case, and sometimes the behavior develops later, but not later than early adolescence, okay? So not much later, not late adolescence, okay? So the beginning of teenage years. When it usually starts later, it's usually after something has happened. So enough after a family breakup, the parental breakup, okay? In these cases, when it starts later, usually the prognosis, okay, so how the outcome, how good they are eventually, how well it's the eventual, how well the child functions eventually is better, okay? So when it starts later, it's better than when it starts earlier, okay? Those that develop ODD or present with ODD earlier or conduct disorder earlier are at an increased risk of abuse by their parents, and they are also at increased risk of school dropouts. Now, this risk of abuse by parents is obviously two-way. When you've got abusive families, the risk of ODD is higher. But when you've got naughty children, the risk of parents losing control of their emotions is higher as well. So it goes like both ways, okay? Later on, children with ODD, especially if they develop conduct disorder, can commit serious crimes. And they may eventually need long-term care in the mental health system. So long-term care, not necessarily and not usually in the mental health system because of crimes, but because they may go on to develop chronic mental illness like depression, serious anxiety, substance abuse, okay? Comorbidity, something that Pamela mentioned in the introduction. So when you have two conditions occurring together, so very often in psychiatry, but not only in psychiatry, we can have more than one condition together. And in this case, ODD and ADHD frequently occur together. Again, the figures vary a lot. We can have 30 to 50%, so quite a high comorbidity, as Pamela was saying, okay? It is very important to distinguish, okay, to make a difference between which features are due to ODD and which are due to ADHD. And I'll tell you why it's important. So very often parents will come and say, you know, we gave him, for example, methylphenidate, and he's still answering back. Yes, because answering back is not really a feature of ADHD, okay? So it's important to distinguish what are the symptoms of ADHD. And there's a whole list. There's the attention criteria, there are the hyperactivity criteria, and there's the impulsivity, okay? And then there are the features of ODD, which I have described. It's important that when you're discussing with your doctors what has improved and what hasn't, okay, with medication of ADHD, for example, you keep in mind what is due to what. Although obviously there is overlap as well, okay? So for example, a child might not be obeying you because they are not paying attention because of the ADHD. So they're honestly not listening, or they might be not obeying you because they are actively defying you. Okay, so even when we're asking you questions for assessment, we'll be usually very careful to bring out this distinction. Okay, so for example, a child might be careless because of ADHD, but they also might be rushing their homework to get rid of it as soon as possible because they want to play on the computer all the time, not because they have ADHD, but because they don't care. Okay, so it is a bit difficult to distinguish, okay, but it's important to try. Also, very often there is a comorbidity with learning disorders, as I mentioned before, and communication disorders, okay, where you find it difficult to understand or to explain, okay, for the simple reason that obviously if you're not understanding well, it's more difficult for you to follow instructions, and also if you cannot explain yourself well, the tendency is to lash out. Okay, there's also a comorbidity. It's less than the ones I mentioned, but it's still there, with anxiety disorders and mood disorders. These I feel are frequently missed. Okay, so very often children might come to me and they're being very angry or always in a bad mood, disobeying, and in actual fact, they might be anxious or depressed. Okay, this might actually present quite early. So in one study, 14% actually had anxiety besides ODD, and 9% had depression. So although it's not as common as the ADHD, it's quite important. As I already said, early onset of ODD strongly predicts eventual development of conduct disorder and behavioral problems and other difficulties. So early intervention, in the way that I'm going to explain later on, is very, very, very important. Okay. Now I did the brackets here because traditionally we believed that the ODD developed into contact disorder. More recent studies suggest that they might be totally distinct, in fact. Okay, so whilst there is an overlap between the symptoms, they might be distinct. Okay, genetically there are studies to show, okay, and hereditary studies, and also the actual features. Okay, the ones that I mentioned before, the 3 clusters. Okay. So the conduct disorder, there's more of the vindictiveness, for example. Okay, so those with ADHD and ODD, or ADHD and conduct disorder, tends to have more severe and persistent behavioral problems, okay? And they're also more likely to have also the mood disorder that I mentioned, okay? The ones that have these 2 conditions together, so ADHD and ODD, or ADHD and conduct, are then at a higher risk of abusing drugs, okay, using and abusing drugs later on, okay. Those that are the ODD type, which are very angry and irritable, are at higher risk of eventually having also the mood disorders. Those, on the other hand, that are more vindictive, as I've been saying, are at risk of conduct disorder. Okay, so the type of ODD is also important. What I mentioned about substance abuse and abuse is another reason why it's very important to assess early and intervene early. Okay, so what causes ODD? Okay, it's usually a mix of all of these that I'm showing. So personal characteristics in the child, how the parent and child interact together, and other environmental factors, okay? So it's a mix of the 3. Let's go to the developmental factors. Some children have a difficult temperament, okay? You realize from early on they're difficult to soothe, they cry all the time. Basically, the mom is totally overwhelmed, especially if it's the first baby. Okay, some children are more difficult than others. Okay, those of you who have more than one child will know maybe this one was more difficult than the other. We all have different personalities, and it starts from when we're children. Okay, the high motor activity. Okay, children that are more active are more at risk. Those that have more extreme emotional reactions, okay, they get upset more easily, and it's more extreme. There's hereditary, it's hereditary as well, okay, so there are the genetic factors as always. And as I mentioned, the ADHD and learning difficulties. Parental factors, okay. So if in the early years, the child has a lot of different caregivers or they change from time to time, maybe displacement from the actual biological parents, for example, to later foster, okay, these having different child caregivers can increase the risk. Harsh, inconsistent, or neglectful parenting, okay, someone who's too strict, as we're seeing in the picture. Inconsistent, okay, so for example, saying, no, you cannot eat sweets, and in the next moment, because you're on the telephone and you're busy and don't want a nagging child, you tell them, okay, take the sweets, okay? So it doesn't need to be aggression like I'm showing in the photo. Changing, saying one thing as a rule and changing the rules or the targets continually will put the child at risk of ODD. Or neglectful parenting, okay, not being present as a parent, okay, so not being present because you're busy and not being present because of needing more skills, okay, so when we say present, not only being present in the room, but being involved with the child, okay? You see them playing in a nice way. Oh, how nice you're playing, well done. Look how nice the drawing that you've done, okay? So being present. Poor communication with school, okay? It helps to have good discussions with your school and knowing what's happening and listening. Serious conflict between the parents, so parents that are having arguments, okay, or in the process of separation, okay, or abuse between the parents, okay, be it verbal, physical, whatever. History of mental health problems in the parents, okay, partially because of genetics, but also because of what the child witnesses. So depression, ADHD, ODD, antisocial personality disorder in the parent or both parents, substance abuse, okay, a forensic history in the parents, okay, this put the child at more risk. And the environment, okay, unfortunately, if we live in a neighborhood where there's a lot of poverty and there are gangs around, it would put the child at risk, okay. Also, in the same way as happens at home, oppositional and defiant behaviors can be strengthened or reinforced through attention from peers, okay? So for example, the child does something, defies the teacher repeatedly in class, and the children will sort of admire him because he is making a fool out of the teacher, okay? This sort of encouragement by people his age will not help, obviously. Also, inconsistent discipline from other authoritative figures, such as teachers. So not only if the parent is inconsistent, even if teachers are inconsistent, it can add to ODD. Okay. How do we reach a diagnosis? So obviously there's clinical assessment, which means when we see the child, we ask you for what's happening, we ask questions to the child as well, and we observe, okay, so that's the clinical assessment. Then there are what we call rating scales, like questionnaires. Some of them are for you to fill in, okay, some of them for the teacher to fill in, okay. Those are a few that are on the screen, okay. And we also carry out an assessment for other conditions, okay. So obviously, if you come with these sort of behaviors, most likely we're going to assess also for ADHD because there's this high comorbidity, okay? We might want to carry out something called the psychometric testing, where we see the cognitive, okay, how the child functions, for example, how they understand language, how they express themselves, their problem-solving skills, okay, this sort of thing. And at the end of that, we can see if everything matches together, we can come up with a diagnosis. How do you manage oppositional defiant disorder? So, as I said before, once we've done all that assessment, we would again discuss as a team, okay? And the team involves the psychologists, us psychiatrists, obviously, our occupational therapists, the social worker, okay? The speech therapist now as well, and the nutritionist, okay? We discuss all the nurses, we discuss all that together, and we see what's more suitable, what should be included in the plan, okay? The most important thing, okay, and the one that we always start with, because it's the most important, is positive parenting skills, okay? So we will advise a positive parenting skills course, okay? I will go further into this one. If ADHD is present, okay, you manage ADHD, including but not only medication, okay? So there are courses, it's also a positive parenting skill for ADHD, okay? And there are other techniques, behavioral techniques that can be suggested for ADHD and other management, okay, or occupational therapy, etc. If learning difficulties are present, you have to address these difficulties, okay? So assistance in class, okay? Techniques usually that are provided by school, okay? If there are any family stressors, okay, the ones that I mentioned in the family, so for example, mental health problems in the parents, you make sure that you refer the parents for help, okay, to a psychologist maybe, or to a psychiatrist, or maybe they need to go to family therapy, okay, or maybe the couple needs to go to couple therapy, okay. So, or there are financial difficulties, so we would need a social worker to see whether we can help in any way with employment, okay. So you address any family stress factors, okay. You provide sort of therapies that enhance problem-solving skills, okay, and communication between the parent and the child, okay. The problem-solving skills are very important, okay, so both us as parents and also the child. So when you are stuck in a situation, okay, if there's, for example, conflict, the child wants to stay on the PlayStation more and the mommy wants him to study more, okay, how do we reach a happy compromise, for example, okay, without a whole fight, okay? So conflict resolution and coming up with solutions and possible brainstorming possible outcomes. We have anger management skills also at SIPS, okay? So we can offer the child himself or herself anger management skills, okay? Which includes the problem-solving skills, so recognition of emotions, labeling emotions, realizing that your mood is changing early, okay? What to do about it, okay? How to calm yourself down. If you're angry, how to manage that anger without hurting anyone or doing something that you later regret, okay? They're quite fun, these groups, okay? They involve a lot of play activities as well with the therapists. They usually enjoy them quite a bit, okay? But they're very helpful. Family therapy, I've mentioned. Social skills, okay? So we might need to help the child in the way they communicate with other children, okay? And also with adults, okay? It's good to involve school, okay? So that any intervention, first of all, to get information, and also to make sure that the right interventions are being used at school, and also to be able to keep the same sort of management at home with school, okay? So that both school and parents are using the same strategies to improve behavior. As I said, the earlier you intervene, the better, because you can prevent later problems such as drugs and delinquency, okay? So crime. The parenting skills, okay? Parenting a child with ODD can be very, very exhausting and very frustrating, okay? It's already tiring to parent a child with ADHD, let alone with ODD, let alone if it's both, okay? Parenting is not easy in the first place, first of all, even if your child has nothing. So any sort of parenting course can only help. And if you do more than once, it's even better because you always learn something new, okay? Behavioral parenting interventions are first line in the younger children, so it's what we use first. So don't please be shocked if you come to SIPS and the first thing I tell you, because when your child is aggressive, is that I'm going to give you a parenting course and I do nothing to your child, okay? You are going to be taught how to help your child and be the therapist to your child, okay? Because your interventions at home can all make all the difference, okay? And it's much easier, it works much better to teach you rather than children who are still not communicating well, in fact, okay? So the aim is to help parents manage the behavior, the disruptive behavior, by decreasing unintentional positive reinforcement, we call, of disruptive behavior. Let me explain this. So very often what happens is when a child is playing quietly and nicely, they're playing quietly, I can do what I want, I can do some housework, okay? So when they're playing quietly, we are relieved and we ignore that behavior, that positive behavior. On the other hand, as soon as the child starts nagging or throwing things around, okay, we give them attention. Probably it's negative attention, but for the child, that negative attention can be a positive reinforcement. It can be a way of getting the much wanted mommy time or daddy time, okay? So without wanting, we might be encouraging the bad behavior because we only stop from what we're doing and talk to them and look them in the eyes when they're being naughty. Okay, so this is one example. There are several other examples of how we might unintentionally encourage the bad behavior. Okay, we need to give appropriate consequences. I will talk more about consequences. The emphasis is on appropriate. Okay, we help them have a more timely, consistent, and appropriate response. So it's useless. Something happens, especially with the younger children, and 3 hours after, we are angry with them about what happened. It has to be timely. It has to be something happens and we discuss it and deal with it at that time, okay? Because that's the most effective time. Later, the child has already forgotten exactly what was happening. You have to be consistent. So if you cannot sometimes allow a behavior and sometimes not allow it, or say that there's a consequence and then not give it, okay? Reason being why you should never threaten them, for example, jekk ħatamelek ħandaħlek l-isptar, because I'm not going to admit them. So don't promise things that are not going to happen. Okay? And it has to be appropriate. Okay? So if you're going to give a consequence, and there are very few, there's a way of giving consequences, okay? They have to be appropriate to what they've done. So small naughty thing, small consequence. Obviously, the more if they become violent, obviously there is going to be a more important consequence, okay? Your style must be a positive parenting one, okay? And there are parenting skills courses that teach this positive parenting style. One of them is The Incredible Years, which we do at SIPS, okay? It's developed by Webster Stratton. I will talk a bit more about this, okay? A 2012 study found that parental interventions, okay, that were based on behavioral therapy and CBT were as effective and as cost-effective for improving the conduct problems, okay, and the parental mental health and parenting skills, okay. So these parental strategies that I'm mentioning, okay, and CBT work very well to improve parental skills, the child's problem, and also the parent's mental health. Okay, so what is Incredible Years in short? Okay, so I thought we describe it a bit, because if you come to SIPS, we would be offering this to you if your child has ODD or Incredible Years or other similar difficulties in behavior, okay? It's a series of programs that was designed to prevent and treat emotional and behavioral difficulties in children between the ages of 3 and 10, okay? It was developed in the University of Washington by Dr. Caroline Webster Stratton, okay? And it contains 3 separate training programs, one for parents, one for teachers, and one for children. The one we offer is the one for parents. The one that I would really dream of happening is the one for teachers, okay? I'd like to get there. But anyway, you can buy the book. By the way, I forgot to put the picture of the book, but you can buy the book. You can find it online, okay? The goals of the parenting program are to promote parent competencies, okay? So to teach you skills, okay? And encourage you to use them, to strengthen families by increasing the positive parenting technique, by improving the bond with your child and the attachment, okay? And also with the program, you improve your self-confidence about your parenting. Unfortunately, very often as parents, we're always like, but I'm not doing enough, or I'm not a good enough mommy or a good enough dad, okay? These type of programs will help you with that, okay? Because it will improve your skills. It increases the parents' ability to use play in order to teach the children how to communicate verbally. It increases when you play with them, it increases their academic performance, how they persist in what they're doing, okay? And their social and emotional development, how they express themselves vis-a-vis emotions, okay? This you can all achieve with playing with your child in the right way. So it's not just playing, but what you say while you're playing with your child, the encouragement, the positive comments, okay? When you're cooking together, for example, or when your child is drawing and you're looking on, okay? Or when the child gives you instructions how to play a game, okay? And you listen to them and follow their instructions. Okay, so you reduce also the critical and physically violent discipline. So things like things I hear. So for example, either passing negative comment, u inti, dejjem hekk, ħlif affarijiet ħżiena ma tagħmilx dejjem b'xi waħda, inkwiet waħdek, okay? You're always breaking things, or you're always answering back, okay? So these negative comments, you never do anything right. Or for example, the child does something nice in front of friends or family, but it's only here because you're here, so they're never like that. These critical comments, okay? Or even worse, obviously, slapping them or hitting them, or so on and so forth, okay? And on the other hand, increases positive discipline strategies. So, for example, ignoring behavior that can be ignored. Obviously, you're not going to ignore aggression, okay? But ignoring what's not important, okay? Not needing to comment about every single behavior, or else using redirecting strategies, okay? So if the child is engaging in something you don't like, instead distracting them with a positive behavior, okay? Like, for example, I think you're bored. What about we play a game of cards, okay? So something like that. Or logical consequence. So if you're going to give a consequence, what I was mentioning before, logical consequence. The child takes long to finish their homework, and you give them an option, okay? It seems you're taking long to finish your homework. If you continue taking so long, the time left to play on the computer is going to be less, okay? You can either continue wasting time, and then you will have less time to play computer, or we can try and finish on time, so you will have more time to play. Okay, you're giving them a logical consequence. So you're taking off the PlayStation time, but it's not because you're being nasty, it's because they lost the time, because they're wasting it. Okay, it's a logical consequence. Timeout, okay, sometimes some timeout, not in a punishment way, okay? So it seems you've got big emotions at the moment. Maybe we need to calm down. Let's sit down quietly where there are no distractions, okay? And problem solving. Okay, you improve parental self-control, okay? So controlling your own emotions, okay? And modeling the right way to control emotions. You improve parental depression, anger management, communication skills, and problem solving, okay? So in the course, you will be also, the techniques you learn to help your child are also going to help you, in fact, control your emotions. You encourage them to increase family support networks. Sometimes we need help. There's no shame in asking, okay? We all need help and support. If not from family, nowadays maybe friends, community, okay? And you improve your communication with school, okay? And your involvement in the child's academic activity, okay? This is the Incredible Years Pyramid, okay? If you come to the course, you would be seeing more of this and working on each and one by one to learn about it. It's central to the program, okay? And it shows a hierarchy of parental strategies. So the ones at the bottom, okay, where it's wider, where the pyramid is wider, is the strategies that you have to be using often, okay? You use them as much as you want. So problem solving, giving them attention and involving them in what you're doing, playing with them, listening to them, talking, okay? You encourage them, you praise them, not for nothing, obviously, but when they're doing something good, you praise. Useless praise is not good, so don't praise for nothing. But when they're doing something, try and catch them doing nice things. When you do catch them doing nice things and they're doing something positive, praise them and encourage them, okay? Celebration for good behavior, okay? You set limits, it's important, okay? You have clear household rules and you keep to them and you're consistent, okay? The consequences, as you see, are at the tip of the pyramid. So whilst we do use them, we use them very sparingly, okay? We don't base our parenting on consequences. Exactly. Okay, so because Pamela told me there might be some teachers listening, I thought I would add a few tips for teachers in the classroom, okay? Also, these tips might be useful to parents when to make sure that these things might be happening, okay? So for maybe in IEP and MAP sessions, okay? You're supposed to make the lesson as interesting, engaging, and interactive as possible. Obviously, you do this for all children, but with children with ADHD and ODD, it's even more important because they get bored easily. When children get bored, they get up to trouble. You make sure that the child with ODD is not left out of any activity, and you keep them as actively involved as much as possible. Okay, so you can give them little tasks to do, little responsibilities, that helps. You do a daily schedule, okay? So you do a sort of timetable where the child knows what to expect during the day. If you're going to change the schedule, advise them from before, okay? It helps. You need to be consistent, just as I said for the parent. As a teacher, you need to be consistent, okay? Consistent with the child and consistent with all of them, so you treat them all the same. You build on the positives, not on the negatives, and you offer incentives, okay? So goals to work to, okay? Maybe little rewards, which are not necessarily objects, but could be as a responsibility. So whoever is behaving best might get to take care of the class pet, for example, or can go and do an errand for a teacher. They love these errands, so you can use that. This stress as a teacher, it's tiring, okay? If you have a child in the class or two who have ODD or ADHD, it's very tiring. Talk to your colleagues, get ideas, see what you can do better, get supervision, okay? Engage in healthy lifestyle so you yourself don't get overwhelmed. If you have a child with ODD or ADHD, I must say, seat them next to you, okay? And away from areas of the room that are high in traffic, okay? So don't put them right next to the door where everyone's coming in and out, okay? Or next to a window. This is for ADHD, next to a window. Don't put them where they'll get distracted, okay? But for ODD, don't put them where they're going to get into trouble more often because people are passing right next to them, okay? If you can integrate lessons that involve social interaction and in your interaction in class, so whilst in the day-to-day management of the classroom, you can use moments when there are conflicts between the children to actually show them how to resolve conflict, okay? That is very helpful and will be one of the most important lessons they learn in class. It's important that you have clear and non-negotiable rules in your classroom with clear consequences, which I will explain again, for children who do not follow the rules. Students with ODD are most successful if you keep them busy. So keep them busy and try to minimize the time when the classroom is not doing anything, because that is when they will get into trouble, okay? Try and move smoothly from one part of the day to another, okay? So avoid long transition times when there's nothing happening, okay? Positive reinforcement, once again, is very, very, very important for all of them, not only for the child with ODD. As I said, for the parents, praise students' work appropriately. So if it's merited, okay, but praise them. There's always things to be praised. So choose the right things to praise. Treat students with respect, even if you're disciplining them or if they've done something wrong. You treat them with respect. You discipline them in order for them to grow, not to shame them, okay? So when possible, even try and do it as privately as possible. It's not always possible, but when you can talk to them before or after the lesson, or just lower yourself close to them enough so that they can hear, it's better. Avoid power struggles. Same applies to parents. It's useless getting into power struggles because no one will win, okay? Think about your priorities and choose your battles. Otherwise, you're going to be battling wars all the day. Avoid stop, don't. These negative words might actually work against you. It's good to create a space in the classroom where the student can go and calm down. So many classrooms nowadays have a quiet spot at the back or on the side where they can go and maybe calm down. Maybe there's a book or some cushions, okay? Maybe you could have some sensory things that the child can use, okay? it's good to find out what makes the student tick and use it to motivate them, use it to make them look forward to that thing, okay? Important, same as for parents, model to your students how to deal with feelings. So if a child sees the adults around him dealing with feelings and emotions in a healthy way, they will learn how to do it themselves. Involve physical activity as much as possible so that the excess energy and the energy they have, they use it in a positive way, not in a destructive way. And you can also use breathing exercises with all the children in the class. This will help them take a break in a stressful day, okay? But it will also help the student who has ODD use it when he needs it to manage his emotions. As I mentioned, consequences, okay? They should be a last resort, okay? In the classroom, you go step by step, so you don't go from child misbehaving to immediately giving detention or missing all the break, okay? So maybe you can start, listen, if you're wasting time and it's taking so much time for you because you're distracting the other children in class, you are going to continue this exercise when the lesson finishes. So you're losing 2 minutes break, okay? And you go step by step. You don't take away all the break on the first instance, okay? You give choices. So we can either do this or we can do that, okay? So like that. You keep your cool. So when you're going to give a child a consequence, you don't shout or scream or show you're angry. You detach yourself. You give it without emotions, okay? As a matter of fact, you need to be firm but fair. Okay, and the consequence must fit the crime. Okay, and the consequence must be suitable. Okay, so it's one thing if the child has wait a minute. Okay, it's one thing if the child has punched another child. Okay, it's another thing if they drop the pencil on the floor whilst you were explaining, okay? It's not the same thing. And be consistent, okay? So whilst you've said you're going to do something, then you have to follow it through. Going back to management, okay, there's psychotherapy that we offer. In young people, we offer individual therapy, but if there is also parental involvement in the psychotherapy, it improves outcome, okay? Child-based therapy often focuses on problem-solving skills, okay? Group CBT has been found to decrease aggressive behavior, okay? So where our anger management courses, in fact, include CBT techniques and DBT techniques. DBT is dialectical behavior therapy. We use it in older children, okay, for emotion regulation, okay? We do offer DBT as well, but we use it for children 13 plus. Because it takes a bit more, you need a bit more maturity and reasoning skills to be able to benefit from it. And also collaborative problem solving. So you can have the child and parent and you teach them how to problem solve together. Finally, medication, okay? I mention it last because it's the least important, okay? We don't use it as a first-line treatment, but it can be, I'm talking about ODD, obviously, okay, not ADHD. It can be helpful in conjunction with behavioral interventions, okay? So we can use it, but it's going to help if you're also doing what I've been mentioning. Unfortunately, many people come and want only this part. This medication will work if you're also doing the rest. On its own, it's not going to do much. It's important to treat comorbid conditions. So if the child has ADHD, you do give medication for the ADHD, okay? The most evidence would be for the stimulants, okay, to help with the ODD behavior. There's less evidence for atomoxetine, okay, Strattera. The stimulants are methylphenidate, okay, Ritalin, Concerta. And there's some evidence for clonidine as well. Sometimes we can add mood stabilizers or atypical antipsychotics. The atypical antipsychotics especially can be helpful for aggressive behaviors present. Usually we use either aripiprazole or risperidone, okay? Both of them do increase a bit appetite, okay? So we have to be careful to monitor weight, okay? Risperidone usually does it more than aripiprazole, okay? We usually use small doses. If you use high doses, it can make them sedated. We don't want sleepy children. Both of them, especially risperidone, though, we would need to take regular blood tests. We might need to monitor ECG sometime, okay, the blood rhythm, okay. Would need to monitor lipid, the cholesterol levels and sugar levels as well, okay, because they increase appetite. If the child has anxiety or depression, we would give antidepressants, okay, if the psychotherapy for these conditions hasn't helped. Outcome. So it's not very well defined, so there's a lot of very difference in the studies. Nock et al. In their study showed that about 70% had symptom resolution by 18 years, but it can persist into adulthood, okay? The earlier the onset and the male gender is usually at higher risk of having more severe symptoms. If they have family instability, if there's poverty, okay, if there's arguments between the parents, okay, this increases the risks of developing worse symptoms. They are also at risk of developing eventually antisocial personality disorder. This is a personality disorder in adulthood over 18, over 16, and usually linked with criminality, okay, but not necessarily. Adults and adolescents with a history of ODD have more than 90% chance of being diagnosed with another mental illness in their lifehood. Increased risk of social and emotional problems as adults, increasing the risk of suicide as well. And increased risk of mood disorders such as anxiety, depression, and bipolar and substance abuse. So basically, that is why early intervention is important, because thanks to early intervention, okay, so the parental strategies, the therapy, the anger management, the classroom management, all these will decrease the risk of worse outcome, okay? So that's it, basically. Let me go out of here. So that was the presentation.
Yes, thank you, Dr. Lorraine. And there are already some questions in the chat if you want to have a look.
Okay. Mela. Let's go down slowly. This one is in English. What can I do? A positive parenting skill for, yes, when can I do it with ADHD? Okay, so I meant where? Okay, Mela, SIPS, we do positive parenting skills program. So if your child attends SIPS in Malta or in Gozo, we can offer you the Incredible Years program. At the moment, we're doing them online, okay? We used to do them face-to-face, but I think, in fact, we've been having better attendance ever since we've done the online ones. Okay, at the moment, Monday, we're going to start an English one. January, I think we'll have one in Maltese, okay? Besides our parental skills program, I believe Appoch also offer it, but for families with difficulties. Obviously, ADHD family offer, I believe it's also a positive parenting skills program, no? It's also based on positive strategies. Natasha, Dorothy.
Yes. We do offer parental skills, and hopefully we'll be offering also the other one.
Okay, so
But for now, we're doing parental skills, and one should start in November.
okay, and it's based on positive parenting, I assume,
Yes.
as well.
Yes.
Okay, so there are various programs. It doesn't need to be the Incredible. The Incredible Years is the one that we use, okay? But there are several parenting skills courses that happen in Malta, one of them being for free from ADHD Malta as well. Okay, my 14-year-old has ADHD and ODD. What type of medication is used for ADHD and what type of meds are used for ODD? I think I answered this, but as I said, okay, so the ADHD, make sure that the ADHD is managed properly, okay? So we have the stimulants like Ritalin or Concerta, all right, or Xanidate, and there is atomoxetine, Strattera, there's clonidine, okay? There's the medication. Your psychiatrist will guide you what's the most appropriate. And the ODD medication that I mentioned. However, the ODD medication should be a last resort. Please don't look for ODD medication before you've at least started behavior therapy and parental strategies, unless maybe one reason when I usually start early, if there's dangerous behavior and someone's going to get hurt. There I might go a bit faster with the medication. Kindly inform firsthand when the one for teachers is on. Inform me. Mary, of course. Emery. Tell Education Department to pay for it. Please.
Kemm nixtieq, imma ma jiddependix minni. Imma ngħaddih il-messaġġ.
Yes, I always do. Hopefully one day we get there. Yes.
Okay.
But obviously, even in the sessions that you have, fakajna, what do you call them?
Kien ikollna l-behavior forums, imma bħalissa
Yes.
waqqafthom.
In those, I mean the parental strategies. Actually, Anne-Marie, there has been side note for those of you more on the therapy side rather than the receiving it. There has just been a training course. Okay, there has been it was offered. There was a course in Malta to teach Incredible Years so that then you can teach it to others. Okay, so that you can do the course yourself.
Okay, imma min kien sar? Minnkom?
No, kien sar, aħna ma nistgħux nofruh. Low tiġib in-nies minn barra biex jgħalmuh. Okay.
Ġifieri però sar
Sar reċenti u kien hemm xi nies li attendew, kienu soqgħod insemmi kumpaniji ma kien hemm kumpanija li offritu, okay, nimmaġna li jerġa' jiġi offrut, okay, jekk pereżempju jkun hemm minnkom li titħajru tagħmluh. Ok, naħseb fil-fatt minn iżgur hekk xatt minn ADHD Malta tagħmlux.
Fil-fatt għandna xi ħadd għadu spiċċa l-kors tal-Incredible Years issa. Ġifieri l-qoddim kif awtorizzat kollox li tista' tibda let's say, kunu nistgħu nofru anke l-Incredible Years lill-membri tagħna. Kif qed l-ewwel parental skills nofruh diġà, u ħajbda wieħed mid-November nippreparaw il-formula għal min jixtieq jibda kif tgħid. Juri li jixtieq jipparteċipa f'dan il-kors. Ġifieri dawn affarijiet imminenti kważi tista' tgħid għax mid-November parental skills u Incredible Years most probably soon after.
Min hu interessat li jitgħallmu wkoll ħalli jkun jista' jgħallem dan il-kors fil-każ jikkuntattjawni ngħidilkom min għamlu u naf li ppjanat li jerġgħu jagħmluh fil-futur qrib. Okay, ovvjament bi ħlas, imma dan tal-ħlas ovvjament huwa biex tallem, mhux biex tiġu intkom il-ġenituri, imma jekk xi ħadd bħal teacher tkun trid issir trainer biex tkun tista' tagħti dal-kors, ovvjament huwa bħalma għamilna aħna bil-ħlas, ħallasna għalik. Okay. Mela, what is antisocial personality disorder? Mela, antisocial personality disorder hija kondizzjoni fil-kbar, okay, rid tkun m'għadekx tfal, okay, għax il-personalità tkun għadha tiżviluppa fit-tfal ara ma nagħmlux diagnosis ta' personality disorder. Hija personalità fejn inti bażikament m'għandekx empatija għal ħadd ieħor u tuża il-personalità tiegħek biex tieħu dak li trid, okay? Pereżempju, mhux se jkollhom remors jekk jisirqu laqwa li ħadu l-flus, jew jekk iweġġgħu il-ħadd ieħor mhux se jkun hemm remors, okay? Fi ftit kliem, ovvjament ħafna mill-kriminali li taraw jew tisimgħu bihom ikollhom x'aktarx din il-personalità. Manka pereżempju n-nies li jabbużaw lill-partner, okay? Ħafna drabi jkollhom din il-kondizzjoni. Mhux bil-fors din, imma hija waħda mill-kondizzjonijiet. Wasn't here from the sun, not sure if this was addressed. How do you tackle rude words like swearing, saying rude words to LSC when upset and triggered? Ovvjament hemm il-mod kif it-teacher trid tittakilja bil-classroom tips for jekk battaraw ir-recording hemm it-tips li t-teacher għandha ssegwu l-LSC għandhom jużaw fil-klassi. Okay? Ovvjament, throughout it-talk kont qed ngħid how important it is to talk to liaise and work together as a parent, LSC, parent, child, and parents and school. Okay, so obviously, if the child has been rude in class, you talk to the child about it at home. Okay, and you are obviously going to you use the same. You use the same. For example, if the teacher says something, you undermine the teacher. It's important not to undermine the teacher. If you think that maybe the teacher didn't act in the right way, I suggest you don't tell the child this, but you talk to the teacher yourself and clarify what happened. Okay? It's very important to be working together as a team, okay, and cooperating as much as possible. And Mary,
Dr. Lorraine, nista'
comment, yes, please. Yes, thank you. Spiega min inti l-ewwel ħaġa Mary.
Mela, jiena naħdem bħala fuq behavior management ġewwa l-Kulleġġ San George Preka. U lil Dr. Lorraine u l-psikjatri l-oħra nċemplilhom ħafna għax inħobb nikkonsulta qabel ma nissuġġerixxi. Ġifieri naħdmu ħafna bħala tim, ġifieri magħhom is-psychologist ġieli nkellem. Issa rigward il-ħaġa li saqsiet is-sinjura issa wkoll, jien naħdem kemm bħala teacher u kemm bħala LSC qabel ma mort fir-rwol li għandi bħalissa. U ħaġa li kienet taħdem ħafna ukoll meta kelli tfal bl-ODD, ġifieri sa tfal anke għandi dubju jekk kien iċ-ODD jew conduct disorder, li kien jaħdem kien meta kont nagħmel contract. Jiena u l-istudent biss nittargetja il-behaviors tal-istudent billi nagħmel forma ta' jgħidula ABC chart, ġifieri x'ġara qabel, x'ġara dak il-ħin u x'ġara wara, dak iż-żmien semmek kont naf, però llum ukoll nagħmel behavior modification program jgħidulu. Issa, l-ABC chart huwa faċli biex l-LSC tagħmilha. Għax inti tkun taf minn hemmhekk qed tidentifika li ma behaviors għandu diffikultà fihom l-istudent. U mbagħad noħroġ behavior contract ħafif jekk it-tifel hu fil-primarja, mela t-tifel qed jidaj. Mela jiena, if you are going to swear, ħajjiġri hekk, mhux ħajkollok computer time pereżempju. Meta kienet tiġri l-ħaġa, niġbdu barra t-tifel biex ma nwaqgħux ċaċċajt quddiem it-tfal. U nsaqsi lilu issa x'sa jiġri. M'għandix computer, imma għala għax tkellimt ħażin. U inkredibbli f'sena jekk kien ikun hemm inċident wieħed kien ikun ħafna. Ġifieri. Meta ngħidha forsi mhux kulħadd jemminha, però meta tiftiem when you establish a good relationship, communication, u huma jaraw li m'intix qed twaqqagħhom maċ-ċajt, il-behavior ħajamela x'dik hija d-disorder hija l-kundizzjoni tiegħu. Però ħajobdi iktar il-frekwenza tal-affarijiet ħatonqos. I believe in it u isseħħ. Jiġifieri
Dit-teknik ovvjament tajba ħafna tista' tintuża wkoll id-dar, okay? U l-raġuni għalfejn taħdem hija huma varji. Waħda għandek ir-regoli stability minn qabel. Ir-regoli għamiltuhom flimkien. Mhux ħarġet bihom Mary. Ir-regoli ftehmu bihom fuqhom qabel. u ftemu fuqhom qabel. Jisu hemm gentleman's agreement, okay? U fehem għalfejn importanti diġà, okay? U r-responsabilta ta' dak il-behavior hekk mhux NMRI qed tagħti il-konsekwenza, ir-responsabilta tal-behavior waqgħet fuq it-tifel jew tifla. Allura hu stess qed jinduna jiena għamiltek mela ħajġri hekk ir-responsabilità tiegħi.
Issa, biex nelimina wkoll ħafna skejjel sfortunatament u mhux faċli jiena anke bħala HOD noħroġ minnha. Meta jkun hemm tifel li kien aggressiv fil-klassi, it-tfal jindbagħtu d-dar. Mela jiena meta kont LSC ħanerġa' ngħid mhux issa u kont nagħmel dan il-contract, kont innizzel u niftem miegħu l-istudent, speċjalment għax irid inkun wise iktar minnhom kont, jekk jiddejjaq jaqgħad ċajt mal-klassi għax sejjer id-dar għax hemm minnhom jiddejqu. Kont nikteb illi pereżempju jekk inti ħatweġġa' l-sħabek, jiena ħajkolli nibgħatek id-dar għax jekk inti ħatikber u tibqa' tagħmel dawn l-affarijiet barra, inti ħatispiċċa l-għassa. Meta kienet tiġri inkredibbli kif tiġri, inħares lejh biex l-istudent. Niġbdu fil-ġemp. Issa sa jiġri għadli inti x'jiena mhux jiena niddejjaq noqgħod ngħajjad u nwaqqa kaċċajt u nagħmel xeni. Hekk kont inkellimhom għax kienu jifhmuni. Ħajkolli mmur id-dar, imma għala ħanibgħatek id-dar. Għax jekk tiġri barra u bekk inti psikoloġikament qed innaqqas il-frekwenza li l-ħaġa tiġri. Ġifieri biex innaqqas anke dak in-negative reinforcement li bdejt tgħid l-ewwel inti Lorraine li jiena qed nikkoreġġih dejjem. Ovvjament praise kien isir. Dejjem ninkludi spjegazzjoni.
Dan qed nitkellmu meta jkun hemm behavior li aħna nikkonsidrawh serju, ġifieri meta inti tkun qed tabbuża l ħaddieħor quddiem klassi sħiħa, dak li titkellem ħażin quddiem klassi sħiħa ma' xi ħadd dak huwa verbal abuse, okay? Jew li tweġġa' lil xi ħadd, dak huwa affarijiet serji ġifieri hemmhekk waqt li jien għattilkom mhux suppost ikun hemm il-konsegwenzi nżommuhom minimum, ovvjament hemm behaviors li jirrikjedu konsekwenza bil-mod fair u konsistenti u b'mod kif għandu jkun, imma ovvjament anke fil-ħajja mill-konsegwenzi u xal kollha kemm aħna.
Jiena bħala ġenitur kieku waqt IEP jekk ma tarawx preżenti u dana nissuġġerih possibbli jsir contract mat-tifel biftehim. Issuġġeruh b'mod kawtu. Ġifieri, però jiena nemmen li jaħdem if it is presented well u b'mod sempliċi jaħdem.
Ma tiġeħ, dik sempliċi importanti wkoll. Ġifieri dal-kuntratti anke jekk tagħmlu tip ta' behavior program id-dar. Tagħmlu xi 6 tipi skont l-età, ovvjament, ġifieri jekk huma żgħar tiżomma terġa' iktar sempliċi, okay, u tinftiem. U forsi meta jkunu ikbar tista' iżid naqra dak li qed tirrekjedi, ma xorta titżommu sempliċi, għax hekk it-tfal tagħtihom ħafna demands ħajdu diffiċli bes forget it, ħajqtaw qalbu. Inti tittihom xi ħaġa li inti taf li jistgħu jinnexxilhom, għax inti ma tridhomx ifallu, inti tridhom li jinnexxu. Allura inti ħadtihom affarijiet biex jaħdmu fuqhom li taf li b'naqa' effort ħajinnexxilhom. Hemm xi ħadd li għandu xi domanda oħra?
Dr. Lorraine, kemm insaqsik, il-courses li qed isiru s-sibs għax kien hemm ġenituri forsi interessati. Mela qegħdin ngħidu li ovvjament ikunu tfal diġà qed jattendu s-sibs.
Eżattament.
Ikellmu naħseb lilkom jekk ikunu interessati u bħala waiting list, hemm xi waiting list twila ma nafx.
Kien hemm fl-antik maċċem daqshekk għax kemm ilna li qegħdin nagħmluhom online kif qed taraw il-lejla stess. Ma tantx hemm limit għal kemm jattendu m'għandniex problema ta' kmamar f'dak is-sens. Iktar kwistjoni ta' organization għax kull darba ovvjament inorganizzaw wieħed għandna bżonn nikkooperaw konna xi 4 mill-kollegi involuti marbutin. Jidher li huwa xi 8 sessions ta' satejn kull wieħed, 8 jew 10 sessions ta' satejn kull wieħed. Nafżawkom bil-ġranet mill-bidunet li qed naħdmu fuqu bħalissa u li suppost ħadd tiffaċilitalkom il-ħajja li mhux biss għall-incredible years imma t-terapiji kollha li jsiru fi grupp li at any one point in time ikollna il-gruppi kollha li nafu li ħajsiru jkollna timetable, jkollna schedule ta' xhur li ġejjin u intkom inkunu nistgħu ngħidulkom ara mela ħajsir wieħed f'Novembru, ħajsir wieħed f'Jannar dan ħajkun bl-Ingliż dan ħajkun bil-Malti. U meta intkom tibbukjaw għalih jew aħna nibbukjawkom għalih, ħanajdulkom mal-ewwel probabbilment ħatiflu f'dan. Ħalli intkom tistgħu tippreparaw minn qabel ukoll. Jew pereżempju ċertu nies jippreferu fis-sajf meta tfal ikunu bil-holidays jew huma ma jkunux xogħol pereżempju teachers ġieli. Jew nippreferu fix-xitwa għax it-tfal ikunu l-iskola pereżempju. Okay?
Ġifieri anke is-social skills u l-anger management course dak ukoll qed isiru online?
Sorry? Mela, l-anger management course għax isir ma' tfal, iddeċidejna li peress li jsir ma' tfal iktar naħdmu meta nkunu ma' ġembna. Għax nistgħu nużaw il-logħob għandna l-guinea pigs issa minġi u joqogħdu jilagħbu jagħmlu. Le ma' tfal mhux daqshekk, okay? Ġifieri l-anger management waqt li n-numri jibqgħu baxxi nibqgħu nagħmluhom is-sibs, konna għamilna żmien fil-pandemija bqajna bdejna nagħmluhom online, imma rġajna lura li nagħmluhom in the clinic, ovvjament bir-restrictions li għandna fuqna bħalissa, imma l-anger management, id-DBT, okay? Dawn qed isiru in the clinic, okay? Il-one-to-one therapy meta jkunu żgħar nagħmluhom in the clinic, l-adolescenti biċċiet minnhom huma stess jgħidulna li jippreferu kif minn dawk li jkunu qed imorru s-sixth form jew. Okay, dal-kbar ġieli jgħidulna u fil-verità l-adolescenti m'għandhom l-ebda problema jagħmlu terapija online għax they're at home with it. So rajnija taħdem mal-adolescenti ma tantx affettwatna. L-affarijiet l-oħra kollha is-sessions ma' terapisti ma' kulħadd qegħdin face to face, għadna nagħmlu sessions online meta naħsbu li ovvjament il-pandemija għalmitna li għal ċertu affarijiet l-online sessions jistgħu jkunu prattiċi għal kulħadd. Għandna limitation ta' kmamar SIPS, allura pereżempju assessment ta' occupational therapist li tinvolvi biss questionnaire tista' faċilment issir online. Ġifieri affarijiet li jistgħu nħossu li moħanet il-fuxejn, namluhom online, affarijiet oħra.
Infatti, kun hemm ċertu parents li jisommu ħossuhom naqra għax during school hours mhux faċli toħroġ it-tifel mill-iskola jitlef il-lessons u hekk biex jattendi għal-kors. Nifhem li fis-sajf jew forsi nhar tas-sib.
Sfortunatament l-anger management imma peress li l-anger management ħafna minnhom huma tfal in the 7 to 10, 11, fimt, online, I mean, jiġru l-emmulaw, mux qoddim l-screen, nuru l-pet, anyway, ma kienieċ qed taħdem ħafna. Jekk ikun hemm bżonn jkollna nagħmluhom hekk, imma naħseb nippreferu li nengageawhom iktar u anke huma jieħdu gost iktar ta' fil-verità. U unfortunately, nifhem li jkollhom joħorġu mill-lesson, imma hemm bżonnhom kultant.
Le nifhem li face to face aħjar għax ovvjament tip ta' courses hekk għandu jkun. Li forsi tagħmlu ħsieb forsi anke lilna f'nhar ta' sibt pereżempju jew ftit wara
Sfortunatament aħna t-tobba u nurses biss naħdmu s-sibt.
Għaw xi ġenituri fil-ċett qed jgħidu li sibs qatt ma qalulhom daw il-courses. Jistgħu huma stess jgħidu lilkom.
Ajma, ok. Il-biċċa l-kbira, ok. Wara l-ewwel assessment, meta tarakom in-nurse biss ħafna drabi tkun issuġġerit dal-kors. Għax in-nurses għandhom esperjenza biżejjed li jafu li laqas biss mal-fejn kważi għal ċertu behaviors jiddiskutu mal-bqija tat-tim jafu x'san offru. Jiġifieri l-biċċa l-kbira jkunu saqsowkom mal-ewwel ġurnata li tiġu hemm jekk tridux tal-kors. Ovvjament jekk ikun suitable. Per eżempju, jekk iċ-child għandu autism ukoll, ħanajdilkom jien x'aktarx mhux santuhulkom. Għax għall-autism ma ħassejniex li jaħdem dat tip ta' kors, għandkom bżonn strateġiji oħra, okay? Għalkemm ikun hemm behavior simili, nofru korsi ieħor jismu Signet ukoll ikun online, okay? U għattak posta l-autism, ġifieri jekk f'dawk il-każijiet pereżempju mhux se nofrukom l-Incredible Years, okay? Ġifieri mhux bil-fors ikun adattat. Imma u tistgħu ovvjament tistaqsu għalih, nieħdu gost tistaqsu għalih.
Tajjeb, ma nafx hekk hemm xi parents
Għax hemm żdiedu oħrajn in the meantime.
ħabba l-courses li ma tantx offrewlhom hekk.
Okay.
L-aħħar waħda
Mrs. Gaffiero, skużani, imma ma niftakarx fuq xi xinu l-meeting. Għax ma nafx hekk hux miegħi jew ma ħadd ieħor. Imma jekk trid tiċċempel Monday u tiċċekkja, nipprova nara dana. My son has been diagnosed. Can I apply for? Yes, of course. Okay, so if your son has been diagnosed with ADHD, all you have to do is do a referral ticket, okay, with your GP, and we can see him at St. Luke's. Il-referral ticket tal-GP importanti għax hija parti mill-protokoll. Having said that, jekk ikolkom xi rapporti ta' assessments li saru diġà jekk jogħġbok ġibuhom magħkom l-ewwel appuntament, jekk it-teacher jew l-LSC għandha xi informazzjoni jew tista' tiktbilna nota żgħira, napprezzawha ħafna wkoll.
Domanda żgħira minnaħa tiegħi hemm ukoll Michelle Camilleri li għollet idea se titkellem ukoll. Bħala età li qed jiġu diagnosed bl-ADHD, hemm xi età minn meta jibdew jiġu diagnosed?
Iva, minħabba li t-tfal jiżviluppa kollha rata differenti, okay, the recommended age ta' diagnosis ta' ADHD hija 6 years old. Okay, so when they go into primary school. Okay, ovvjament qabel hekk jista' jkun tibdew taħsbu isma' jista' jkun għandu ADHD jew jista' jkun imma at that age kieku jiena mhux nagħmel id-diagnosis, jiġifieri jkunu lesti li tafu li għandkom bżonn tiġu għandna. Okay, jekk tibqgħu taraw dan l-affarijiet. L-istrateġiji li qed ngħidilkom għaqdu bdew għamluhom għall-ewwel, okay? Jiġifieri jekk it-tifel għandu l-ewwel net jekk għandu bżonn jagħmel assessment is-CDA għamluh, all right? Għax qabel l-assessment ta' ADHD tajjeb li wieħed ikun pereżempju marant il-pediatrician biex tara jekk hemmx problemi ta' natura oħra, pereżempju ġol żvilupp tal-moħħ jew pereżempju jekk hemm speech delay. Importanti li tittekiljawha mal-ewwel u tmorru għand speech therapist, okay? Ma li taraw li hemm speech delay anke kollhom 2.5 mal-ewwel morru fitxu l-parir ta' speech therapist għax ovvjament jekk it-tifel għandu speech delay, il-hyperactivity ħad tkun qar u il-behavior x'hekk inti ma tistax tifhem, ma tistax tisprimi ruħek, ovvjament jaffettwa kif iġġib ruħek. Jekk pereżempju qed taraw ċertu fajt fuq kif jimxi jew clumsiness jew skills kif forsi jkunu ikbar kif jaqbdu idejhom l-affarijiet, okay? Jew anke features ta' hyperactivity, occupational therapist, okay? U tista' tibda strateġija l-occupational therapist li ħajjejnu anke l-hyperactivity. Jekk ma jkunux jorqdu tajjeb, kellmu mal-ewwel il-pediatrician, okay? Ħudu pariri fuq healthy sleep routine għax importanti żommu r-rutina biex jorqdu tajjeb jekk ikunu qed jorqdu. Jekk it-tfal ma jorqdux tajjeb, ADHD u mhux. Mhux se jkun tajjeb il-behavior, jekk ikollhom ADHD iktar mhux se jorqdu tajjeb. Imma dik affarijiet oħra. U tista' tibda tiddressja l-irqat u wkoll ħajimprovja il-behavior. Jiġifieri l-affarijiet l-oħra kollha ibdew għamluhom mal-ewwel, parenting skills courses ibdew għamluhom mal-ewwel. Okay? Meta jiġi żmien li nkunu nistgħu nagħmlu assessment tajjeb, għax nkunu nistgħu nibdew nosservawhom anke fil-klassi waħda minnhom, okay? U nkunu tajnihom żmien jimmaturaw. Mbagħad nagħmlu l-assessment. Hekk jew bekk il-mediċini ta' ADHD rari huwa indikat li tihom qabel 6 snin, rari ħafna ħafna ħafna.
Fil-fatt Dr. Lorraine kellna xi parents li tfal qabel 6 years ġew tawhom ir-risperdin ġifieri.
Yes, jekk ikun hemm eżatt. Jekk ir-rispa dawn
il-rekomandazzjoni,
unfortunately Malta nieħdu pjaċir nieħdu shortcuts, okay? Kif għadd, ġieli jkun hemm il-post u l-lok fejn għandu jingħata minn speċjalista ta' tfal ir-risperidone u l-aripiprazole. Imma niddejja ħafna meta xi ħadd ikun ta' risperidone u aripiprazole qabel biss ma provajna il-parenting strategies, per eżempju, li semmejna. Okay? L-ewwel għandna nippruvaw l-affarijiet l-iktar li huma indikati. Issa, ovvjament, iva, ħajkun hemm tfal li tant ikunu all over the place, tant ikunu disturbati li laqqas biss se jagħtuk l-ispazju bħala ġenitur li tagħmilhom dawn l-istrateġiji. Jew tant ikunu jinnaf inkollu ħajaħarbulek taħt ħajweġġaw jew jiġu għandu diġà jkissru dejjem ma nafx kemm il-darba xi ħin. You know, jiġifieri hemm tfal li tant huma qawwijin is-sintomi li iva jista' jkun indikat għax il-behavior stess tkun qed tinterferixxi mat-terapiji l-oħra. Imma those should be the exception not the rule. Mhux għax m'għandix ċans għax għandi x-xogħol ejja nagħtu l-mediċina. L-ewwel il-parenting course naf li huwa ħafna ħin, naf li huwa ħadd ma jieħu pjaċir, issa tgħin qed naf li qed nitolbu ħafna. Aw ovvjament mhux bil-fors għandna aw min joffrihom bħalkom f'ħin iktar adattat. L-ewwel tistgħu taqraw nowadays hawn kollox online, jiġifieri anke Incredible Years Test tista' tixtrih bħala ktieb. Jien nippreferi jekk tagħmluh magħna għax ovvjament li jsir nagħmlu l-kontenut tal-programm u kull darba meta tmorru d-dar tagħmlu dak li nkunu ddiskutejna, tippruvawhom l-istrateġiji, tiġu lura, isma' dik ħadmet jew isma' dik ma ħadmitx, isma' provajt nuża, imma minflok għamel hekk it-tifel, u ovvjament ikun hemm it-terapisti jgħidulek all right, mela min jaf kieku nagħmlu hekk. Ġieli jkun hemm ġenituri oħra jgħidulek jiena kont nagħmel hekk, imma bagħad ipprovajt nagħmel hekk minflok. Taf kemm ħadmet? You know.
Michelle Camilleri, trid titkellem, please.
Hi, first of all, thank you, Dr. Azzopardi. This is such an interesting session. At the moment, I'm a trainee counselor, and I work with adults and I'm working with children. I'm not sure whether you covered this, but does the child have to have an ADHD or a conduct disorder, an ODD diagnosis for parents to be able to access these courses? Or if because sometimes they haven't got to the diagnosis yet, it will still be slowly evolving. Can we recommend that they contact SIPS and attend these courses?
Okay, so if it's purely for the course, no, we won't accept them. Okay, so we don't accept usually people to attend specifically for the course. But on the other hand, if you're referring because the child has this and this behavioral problem, and we're going to be assessing, okay, we will very often offer the course. Now, if there's a doubt, okay, sometimes we have a doubt and we say, what is this coming from? Autism? We're not sure where it's coming from. So in our mind, we're not sure that the course is suitable to the behaviors that we were seeing. We will not offer it immediately, but we will first wait for a diagnosis. But very often it's quite clear from the start.
So basically they need to be clients of SIPS to be able to access the course.
Yes. Sometimes I will add the other way around. So sometimes when I see that the family situation is so chaotic, okay, I might wait a bit anyway. It comes without saying that there's going to be a wait for the diagnosis of ADHD. But anyway, so they're anyway on the waiting list. But very often I would want them not to be assessed immediately for ADHD.
Till the family
so that first I see what happens when parents start carrying out the strategies. And then I get a clearer picture of what actually is going on. Because sometimes, this doesn't happen often, obviously, but sometimes the situation at home is so chaotic Okay. Let me give you a practical example. Okay, so for example, someone who has just been adopted from abroad.
Okay.
Okay, with newbie parents, I mean, they've passed through all these changes. They've come not from an ideal situation. Getting an assessment when they've just come from this scenario isn't going to be in the best interests of the child. So we offer the parenting skills program. Anyway, they're on the waiting list, and then when they're a bit more settled, we can assess properly. So sometimes it works the other way around.
So can I just ask if there is the other way around? If there is, for example, a mental health problem in the parents, and the child's behavior is there is a behavioral problem that is beginning to be seen. So it's not hugely problematic, but there is. Would they be also eligible to eventually, once the parent obviously is stabilized, settled from a mental health perspective? But
even if the parent,
the mental health problem has not
there are two separate problems. Okay, so as regards the child, obviously they need, when they are referred, they have to be presenting with problems that, so we are using a tier system basically. Okay, so tier 1, tier 2, and tier 3, like in the UK. Tier 3 is people that can have some difficulties, emotional and behavioral difficulties, but they do not reach caseness for a specialized service like ours. These children might probably need to see the counselor. They can be managed. Okay, they can be managed in the community. Okay, the GP. All right, they can be managed safely. They're presenting, maybe there's a bit of anxiety to go to school enough. All right, this sort of small, you understand me. Then there's the tier 2, which is most of our children, which, like for example, most children with ADHD, okay, which need to be seen, need to be assessed, need to be managed probably long term. Okay, and then we have tier 1, who are the more complex cases. Okay, so someone like you're mentioning with a parent with mental health problems, very often, unfortunately, would probably be more of the one. So when we come to SIPS, if we're going to see that the symptoms are so negligible that they fall under tier 3, we won't accept them. We will redirect them where they can
to other services.
Okay. Through other services, because we need to focus on those that really need specialist attention, obviously. In the circumstance where the parent also has mental health problems, whether they're already diagnosed or whether we realize ourselves, we are going to, as part of our complete management plan, make sure that the parents, as much as we can, support them to get their own help. Okay, and where necessary, we also liaise with our adult counterparts. Okay, so we have seen, so we very often work hand in hand. Okay, we have teams in the community in in the hubs. Okay, and we liaise with them so that we make sure that the parent gets all the help they need, and we're working hand in hand. Okay, so sometimes even, for example, if the therapist or the key worker of the mom might come with her to our clinic so that she can then help as well. Okay. By the way, I mentioned key worker. Our tier 1 would have a key worker at SIPS.
Okay. Thank you very much.
There are some
is there any help for children with ADHD and dysgraphia? Dysgraphia safejna fjena iktar l-educational psychologists. Naħseb jagħmlu xi ftit xogħol l-occupational therapist tagħna, ma safejna fien iktar fl-education department. Okay? Ovvjament jekk ikun hemm problemi. I ask you, my son has ODD, he's an angel at school, but then at home is quite trouble with homework. There's reward for them, but still doesn't do it even he wants the reward very much. What shall I do? He's getting angry because he won't have the reward, or he just ignores me. And in the evening, he would burst with hitting and screaming. Can you please answer in English? Yes, I agree. Possible ODD. okay? I think a parent, it's not easy for me to give you an answer like that for one strategy, because as Anne-Marie was saying before, you need to be seeing what is happening before and after. I think a parental skills course such as Incredible Years, okay, would help very much. Obviously, make sure that your one-to-one time doesn't involve only school work, okay? So make sure that obviously after school that he has some time to wind down, because sometimes they would be tired after a whole day. Make sure also that he is understanding what he has to do, that he has understood the lesson, because if a child feels that the homework given is too difficult for them, they are going to get frustrated. So it might be a question not of him not wanting to do it, but of him not feeling he knows how to do it. And he might, either because he really doesn't know it or because he's afraid of getting it wrong, try and keep your calm, take a breath and go out if necessary of the room and come back. Don't go into a power struggle, because it doesn't help at all. If you end up fighting and shouting, it's not going to help. You're going to get tired, you're going to get exhausted, he's going to end up crying. It won't work, okay? If necessary, some children might need little breaks. This is very personal, okay? Some children work better if you start and stop, start and finish it all up, because then it's a problem to get them back to working. Some children need the little breaks, okay? Obviously, make sure that you're not spending too much time doing homework. If you feel that it's taking too much time, please talk to your teacher. And Mary ħajkun kollin ġelek tikom please sawkol. And obviously, please spend time doing nice things with him that he enjoys also, not only the homework, okay? So maybe counteract the homework with some asking him to choose something that he likes playing and he plays it with you. So you're not spending only stressful time together.
Mela, biex najn forsi s-senjura li tkelmet fuq
in English, Anne-Marie, please. Sorry, okay.
Mela, to help in supporting the parent that was speaking about dysgraphia, if she goes to a government school, your daughter, you can inform the head to make an application for the school psychological services, okay? If she goes to a church school, sometimes there is an educational psychologist at the school. So there should be some kind of system if it's a private school or a church school. But if she attends a government school, the head of school has an application for the school psychological services to go and observe the child, the student in the classroom. And then support would start after that observation. Oh.
Okay, so next question. My son is soon 17. Until what age can he keep support through SIPs? So there isn't a straightforward answer to this. So theoretically till 18, different consultants, different way. Dr. Nigel Camilleri sees the complex cases. So besides the tier 1, we have innovations, which is even more complex, okay? Those children that we think are going to become our regular clients in adulthood, okay? So children that have developed psychosis, children already in contact with the law, okay? So the more complex cases, those he sees till, I believe, 21, okay? I usually transfer at 18. However, when there are children that I am afraid that they might be lost to the system, or I think that they are not at the right moment in time to be transferred. So for example, we're still stabilizing on medication, or I still haven't achieved the goals I want to achieve for the child. Before I trust them in the hands of an adult psychiatrist, I will hold on to them till I can. It depends. Okay, if I'm happy that they're doing well, okay, and I think that they can continue seeing an adult psychiatrist, I will transfer them. If I think they don't need to see a psychiatrist anymore, and I need to keep them a bit more so that then I discharge them for good, I do that. I hope that answers your question, Carola. Mela. Pamela passed the comment. I will read it because it's very, very important. Okay. If you start seeing features of ODD or ADHD especially, you've tried the parental strategies that we've suggested. We have suggested medication. Please, please, please give consideration to medication, and please give it. Especially we've been recommending it very strongly, okay? And especially for ADHD, okay? And the earlier, the better in the case of ADHD, because once they grow older, it's more difficult to convince. And once the behavior, the oppositional or the contact behavior worsens, it's close to impossible to convince a child to take medication. So the earlier, the better, even because it will allow therapy to work better. Okay, so if your psychiatrist is suggesting it, especially, please, please, please. Obviously, some people sometimes will try, and sometimes we don't find the right combination. So there might be instances when, unfortunately, the right medication is not found for that particular child. Doesn't happen often, but it might happen. But don't exclude things immediately, please, because as Pamela's saying, unfortunately, they will grow up and they will start experimenting, and sometimes some of them experiment with drugs then, and bigger problems ensue. Naħseb dawk huma s'issa m'hemmx iktar.
Il-fatt biex inkompli ftit miegħek aħna tal-ADHD Malta, ovvjament niltaqgħu anke ma' adulti li għandhom l-ADHD. U xi ħaġa li jsemmu speċjalment dawk li meta kienu tfal ma ħadux il-medication, kemm kif tgħid jiddispjaċihom għax jgħidu min jaf kemm ħajti se tkun differenti illi kieku il-ġenituri tiegħi ħallew ninħu l-mediċina, ġifieri ħafna ma biss ġew diagnosed, ġifieri kieku ġej diagnosed ukoll u kieku ġej ħadd il-mediċina. Ġifieri it's very important. Jekk vera għandhom bżonnhom, no, don't hesitate, just give it to them because they change from night to day, and it's
sometimes it's life-changing. Some children, when we start medication, okay, the parent will come back and say, why didn't I do this before? Okay. Ovviamente, it's not a once-for-all decision, okay? So you can start the medication, you might not, or the child might not, and we might need to change, we might need to stop. It's not a commitment forever, okay? So this is why we work as a team, okay? We will discuss things, you come back, you tell me I don't like this effect or this effect, and we can discuss and change and whatever, okay? But as Dorothy is saying, it's not a question only very important of the substance abuse that Pamela said, but it's also time lost in education, time lost in socialization and making friends. It affects you in relationships, it affects your career, it affects you in many ways. So unfortunately, the longer you take, today, for example, two parents came, we had a whole discussion. I had another condition not related. I had to go to school because the child was so disturbed, and I saw the child in the school setting. The parent had been reluctant to treat. After a long discussion, they decided to give it a try. We started with a tiny mini dose. Today, 1 year on, they came to ask me to increase the dose because the change they saw in the son was so drastic that they are now totally pro-medication. It's not always the case, but very often you can see very important changes.
Yes.
Not a silly question at all. Mela, so someone is asking, I am aware CDIU diagnose children, well, very often we do, but anyway, how do adolescents get diagnosed? So adolescents still 18 with us. Although sometimes they're diagnosed also by educational psychologists in schools who can do very good. They're very good at diagnosis. They're very thorough, actually. So the newer ones, Pam, I'm very pleased to say, I'm seeing very good in the education system assessments. Adults. Adults, as far as I know, in the clinic you can ask, but from what I'm understanding from Pamela, it can be very haphazard depending on the clinic where you go. Pamela will be pleased to say that there are young trainees that showing an interest in developing this thing. So maybe in years to come, hopefully one of my younger trainees will be looking forward to do a neurodevelopmental clinic. We're discussing it today.
That'd be good. So far, adults, fingers crossed, is saying Pamela. Yes, for now, adults, what we do, tell them, obviously, to go to their GP to be referred, first of all. There are the community clinics that do assess, although we had some feedback, so-and-so sometimes, but anyway, but that's the procedure. Or else they can go private, obviously, to a psychologist or to a psychiatrist.
Okay, so someone asked, how do you realize, okay, between, for example, if someone doesn't want to do homework, if it's from ADHD and ODD, okay, if they have both. If they have both, it's probably a mix of both, okay? So ideally, you get your ADHD well controlled so that you get that out of the way, okay? So obviously, if their attention is now controlled with medication, so that helps because they're more organized, they're understanding more in class, okay? They're less hyperactive, hopefully, okay? Their emotions are better contained, okay? So getting the ADHD controlled helps. Obviously, then you have to use the parental strategies that are the same, in fact, for ODD and ADHD that we mentioned before, okay? You have to be using those strategies. What happens when they are 18? When they are 18, if they need, okay, so not all children will need to move to adult services. We have various clinics, okay, so we have the community clinics. I'll try and mention a few. I'm sure I'm not going to manage to mention them all, but we have psychiatrists with a whole team now, okay, so they are complete teams. Psychiatrists, social workers, psychologists, nurses, the lot, okay? And actually, I think they're more efficient than us as regards psychotherapy, fil-fatt. We've got in Paola, we've got in Cospicua, we've got in Mtarfa, we've got in Ormi, we've got in Floriana. I think in that's one għadna ma żviluppajniex. I think those they are, no?
About 5, no? It's 5 or 6. 5.
Yes, I think those I mentioned. Those I mentioned. Unfortunately, once had the Xera one, I think that one we haven't yet found a spot for it. And obviously there's Gozo, where we have our clinics too. Then there's also for children who have learning difficulties, if they fall in the learning disability spectrum, okay? There is Dr. Giorgio, who has an adult clinic in Ormi, okay, where he sees young people there, till adulthood, he sees them there, okay? We also have a gender well-being clinic, so some people with with gender identity issues might be transferred to gender well-being clinic, okay? It depends what's more suitable, okay? We also have a trainee who does clinics in MCAST, okay? So if the child is going to MCAST, they can go to the well-being block, and in the well-being block, there are excellent counselors who they can access, and through the counselor gets referred to Dr. Donatella, who has a clinic there weekly, I believe, okay? And in university, there is Dr. Joe Kassar, who also does a university clinic once a week, okay? So if you're going to university in the same way, there's a well-being block, and through the counselors, you can be referred to the clinic.
I believe there's Dr. Vella van Dakar at university as well.
But that changes depending on who's the trainee. Dr. Vella van Dakar now is back with me.
Oh, Good for you then.
Very happy. So Dr. Daniel wants to become a child psychiatrist. He's obviously a full-fledged psychiatrist now.
Good.
And eventually a consultant too. But maybe we need a few more years.
I have been hearing some very good things about the junior ones, to be honest with you. I'm quite hopeful myself.
Yes, so, we've got very good training now, you know. Yes. We've got a lot. I'm very pleased to say. So for example, when I chose psychiatry, most comments were melet tiġġennen, ħadd more psychiatry, more medicina, jew more jekk jiena żilt psychiatry, jintħalt tabiba biex insir psychiatrist fil-verità. Jiġifieri meta konna nażlu psychiatry, tipo qed taħli l-karriera. Dil-ġimgħa għadhom, nhar it-tnejn ħajibdew 10.
Very good.
10 ġodda magħna.
Dr. Lorraine, can you try and persuade some of them to focus on women? Because this is one of the big problems.
Women ADHD, you mean?
Yeah.
Women and ADHD.
The problems that we're facing.
I don't think it will be purely on women.
But somebody who will take interest in it, you know.
Like the interest that I'm seeing at the moment, we've had someone who enjoyed child but likes to work with adults. So the interest, and I will try to nurture the person, because she's good as well, is to do and it's lacking also in autism, a neurodevelopmental clinic. So a clinic on purpose for adults who have neurodevelopmental conditions in general. I hope she doesn't lose this interest when she goes to work in other places, but as yet, she likes it.
Good. It's very important, because what we're seeing is that a lot of our women with ADD and ADHD are also coming out as having ASD, and the very stereotypical idea of what autism is changing drastically, you know.
In fact, this is the interest. So she would like to be seeing not the actual the autism, the classical autism. She would like to be seeing the fully fledged adults that probably have been missed, and because they are very high functioning and never were diagnosed as young people, because they are so good both as ADHD and autism. So mostly these would be the women. You are right. No bias for the men, but that's it. And so this would be the interest that this person has. And she's also a woman, definitely.
Fantastic. Great.
Okay. Fingers crossed. But the fact that she's asking me where she can train and what courses she can do is a good sign.
If she needs subjects, we can provide her with them. No problem. Lots of them.
She's still a bit too young to be doing individual clinics, but when we are at specialist level, even if they're not consultants, we can encourage them to do these sort of clinics. They would be supervised by a consultant, but they would be able to do their own clinics.
I think this was an extremely, extremely wonderful lecture. So thank you so much, Dr. Lorraine. We're really, really grateful.
I'm so happy.
Show of hands, everybody. I mean, thank you very much.
Thank you so much. It's always a pleasure to meet you all.